زهران
جاهزين؟
صلح هايبرتروفيك دي في اي ناقصين.
ايه؟
صلح الهايبرتروفيك كارديوميوباثي في اي ناقص.
طيب حاضر.
لايف
جاهزين؟ ادوس
جاهزين يا باشا.
يلا.
تمام، احنا كده ان شاء الله.
So good evening everyone and welcome back after Eid al-Fitr vacation. Today is a new session for a live webinar. Today we are streaming live on Facebook. So this is to complete the Thursday clinical discussions at the CEC hosted by the Cardiology Education Channel. We have a very interesting topic tonight. We will be discussing hypertrophic cardiomyopathy in the form of a case-based discussion. I'm very glad actually to have on board tonight two eminent speakers and two eminent moderators and experts in the field. The clinical case scenario will be started by Dr. Mohammed Hosni. He is a lecturer of cardiology at Cairo University and he is a consultant of the cardiology clinic responsible for hypertrophic cardiomyopathy cases at Aswan Heart Center. Dr. Ahmed Asfour will follow that to present the cardiac MRI features of hypertrophic cardiomyopathy. Ahmed is currently a lecturer of cardiology in Cairo University and he's a board certified consultant in the field of cardiac MRI. The moderators today are Professor Karim Saeed, Professor of Cardiology in Cairo University. He is a very eminent figure in the field of cardiology all over Egypt. And my dear friend, Dr. Karim Mahmoud will be the co-moderator with him. Karim is a lecturer of cardiology at Cairo University and he is one of the co-founder boards of the CEC. I will pass the mic now to my dear friend Karim Mahmoud while Mohammed Hosni will start sharing the slides. You may go, Karim.
Hello everyone and welcome again to our weekly webinar. Today we are discussing the HCM, hypertrophic cardiomyopathy, with a group of experts in this field. I pass the mic to my dear friend, Dr. Mohammed Hosni, to start discussing this interesting case of hypertrophic cardiomyopathy. Mohammed, please.
Thank you, Dr. Karim. Good evening, my dear professors and colleagues. It's a great pleasure for me to share in this educational session today. I'd like to thank all the organizing committee, and I'd like to thank Dr. Karim Saeed, who will share us with his limitless knowledge and experience. Going directly to our case, I'd like to comment that all recommendations in the management of our case will be derived from 2014 ESC guidelines on diagnosis and management of hypertrophic cardiomyopathy. Our patient today is female patient, 19 years old. She's a student, not married. She's a tennis player. She started playing since she was 9 years old. Recently, she started to suffer from easy fatigability and shortness of breath in her regular morning tennis training. She sought medical advice in her club clinic with the general practitioner doctor. And she reported that she started to feel chest heaviness after her regular meals, and she had to rest for at least 3 hours after meals before doing her regular activities. She claims that her symptoms are not persistent all the time, and there is a clear fluctuation in her symptoms severity over time. Her doctor started to examine her. His blood pressure was 110/70, heart rate 80 per minute. And in general, and in conclusion, the examination was unremarkable apart from the harsh ejection systolic murmur over the pericardium with no propagation to the base of the neck and neck vessels. Her doctor asked her about any family history of any cardiac cases, and she reported that she don't know, but she added that her paternal uncle died suddenly at the age of 39 without clear cause. This is her ECG. We can see a 12-lead ECG, and first we should see the standardization. It's okay, standardized ECG. It is normal sinus rhythm. It shows marked increase in the amplitude of the QRS in the precordial and limb leads, which denotes signs suggestive of left ventricular hypertrophy. And we can see that there is S-segment depression in lead 1 and EVL, T wave inversion. And also we can appreciate that there is abnormal Q waves in lead 3 and lead 2. So from at this point, I think the differential diagnosis will be one of these lesions. Maybe an aortic stenosis, it may be mitral regurgitation, it may be hypertrophic obstructive cardiomyopathy, it may be pulmonary stenosis, it may be VSD, it may be tricuspid regurgitation. And at this point, from the previous slides, I think we can choose the most appropriate diagnosis from the previous clinical information. We can exclude the aortic stenosis from the propagation of the murmur. It's not propagated to the neck of the vessels as most of the cases of the aortic stenosis. And most of the aortic stenosis cases usually have persistent symptoms, but the patient, our patient, reported that her symptoms are usually fluctuating. Mitral regurgitation also we can exclude it by the fluctuation of the symptoms. Pulmonary stenosis, usually it's a congenital disease, and it would have been detected in the pre-training clinical evaluation, pre-tennis training. And there is no RVH in the ECG. VSD is also a congenital disease, so it would have been detected or detected also in the pre-training clinical evaluation. Tricuspid regurgitation can be excluded by absence of RVH and signs of right side heart failure during clinical examination. And I'd like to comment on two important features of hypertrophic obstructive cardiomyopathy from our little experience in seeing a patient in Aswan Heart Center, that the patient usually report fluctuation of the symptoms. Most of the patient, or a big percent of the patient, usually said that sometimes they can go for 5 flights of stairs and sometimes they cannot go for 5 meters, and usually they have symptoms. And also the characteristic chest tightness and dyspnea after meals, that usually as our patient compels them to rest for 3 to 4 hours before doing their activities. And the presence of history of sudden cardiac death in the history, this further suggests the hypertrophic cardiomyopathy over the other differential diagnoses. She was referred to cardiology consultant, listened to her history. On examination, the murmur intensity changed with dynamic auscultation maneuvers, increased in intensity with Valsalva, decreased with a squatting position, and increased again with a standing from the squatting position. And this further emphasizes the presence of hypertrophic obstructive cardiomyopathy lesion. And he drew the family pedigree of the patient and ordered the echo for her. This table further differentiate between the lesions. We can see here on the left side the lesions: aortic stenosis, hookah, mitral regurg, VSD, BSTR, and we can differentiate between the BSTR and the hookah murmur. BS and TR usually increase with inspiration and increase in the venous return, while the HCM murmur decrease in intensity with increasing the venous return. Remember that any maneuver that increase the venous return, increase the LV size, decrease the intensity of the HCM murmur. We can differentiate the mitral regurg and the VSD from the HCM murmur by the Handgrip Maneuver. The Handgrip Maneuver it's a form of isometric exercise, increase the systemic vascular resistance, increase the LV size, and increase the intensity of VSD and the mitral regurg murmur while decreasing the intensity of the HCM murmur. We can differentiate the aortic stenosis murmur from the HCM murmur by the propagation, and the aortic stenosis murmur is not affected by squatting and venous maneuvers that increase the venous return as the HCM murmur.
So, Mohammed, this is a very interesting case. Before going to the echo, let me summarize what you have said. This is a case of a young athlete that complains of symptoms. It seems like due to LVOT obstruction. Her ECG showed a significant left ventricular hypertrophy. So your differential diagnosis is either, I think, a severe valvular lesion or a myocardial disease, and you favored the myocardial disease clinically based on the clinical examination and based on the history that showed a family history of sudden cardiac death in her family, and the dynamic auscultation that showed increase in the intensity of the murmur with decreasing the preload, as in the cases of Valsalva and standing from the squatting position. So I think the echo is the next appropriate investigation for this patient for diagnosis and assessment of the severity of this condition.
Okay. This is the echo. This is a parasternal long axis view. We can see the asymmetrical hypertrophy of the LV. We can appreciate that the anterior septum is markedly thickened in relation to the posterior wall. And we can see the systolic anterior motion of the anterior mitral leaflet. We can see that the aortic valve looks normal. And on the color flow map, we can see the aliasing that arise at the septomitral contact. And we can also appreciate the posteriorly directed mitral regurgitation, which is very important to report in the HCM case, as we will discuss in the next slide.
Okay, Mohammed, before continuing, I think Dr. Karim Saeed has a comment.
Good evening, everybody. Thank you, Mohammed, for this case. Before going to the echo, I want to give some comment regarding the clinical aspect of this case. Now we have a young lady coming with a very non-specific symptoms. She is coming with new onset breathlessness and chest heaviness after meal. This breathlessness, when we want to analyze it, it may be due to cardiac or non-cardiac causes. Non-cardiac causes such as pulmonary causes, anemias, thyroid dysfunction, and cardiac causes may be related to many disorders, valvular, myocardial, pulmonary hypertension, and etc. And the discomfort after heavy meals may be due to GIT symptoms, disorders, or due to even cardiac disorders, cardiac congestion, or maybe due to ischemia, due to coronary artery disease, or coronary anomalies, or HOCM, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy can induce all of these symptoms if we want to have a unifying diagnosis as well. In this case, we have some clues for the presence of a cardiac disorders, the presence of sudden cardiac death in her paternal uncle is very important issue. The murmur itself denotes high risk features, and it is a flag for a cardiac cause. You gave a very good differential diagnosis. However, the dynamic changes of the murmur give us only two differential diagnoses, either hypertrophic obstructive cardiomyopathy or mitral valve prolapse. Please observe that the same dynamic changes that occur with HOCM also reported with mitral valve prolapse. The differentiation is related to the presence of click, the timing of the click with the dynamic maneuver, as well as the site of the murmur. However, in HOCM, the murmur can occur anywhere, and it tends to be related to the apex as well as to the lower part of the sternum. The ECG is very important in this case. It is definitely abnormal, and it does not support the diagnosis of mitral valve prolapse. And we should recall that it is very uncommon to find a patient with manifest HOCM with normal ECG. Usually the ECG is abnormal. And actually, ECG changes may precede the occurrence of left ventricular hypertrophy in good proportion of adolescent HOCM patients. And this explains why ECG is a good screening tool for HOCM beside echo, and usually precedes the echo. Other point is related to the athletic activity of this lady. Tennis is a vigorous exercise, and in this particular case, it has some impact. First, if it is a HOCM case and this lady is playing tennis, the risk of sudden cardiac death is not low if she has other risk factors. Actually, HOCM is the first cause for sudden cardiac death among athletes. Second, we should make a differentiation between this hypertrophy related to the HOCM and some hypertrophy found in patients, in athletes, professional athletes, especially those having isometric exercise. Third, this lady should stop her sporting till having a full diagnosis and doing a full risk stratification for sudden cardiac death if she proved to be a HOCM patient. So we started with a very non-specific symptoms that can be related to cardiac or non-cardiac causes, and by simple physical examinations as well as ECG, we have a very restricted list of differential diagnosis, and likelihood of HOCM is very high. And now we have even a high risk features for HOCM by the presence of sudden death in her paternal ankle and her athletic activity. And we are interested now to see the echo of this patient.
Thank you, Dr. Karim. I like the note that on the stress of the immediate stoppage of her physical activity till reaching the final diagnosis. This should be done early in the process of diagnosis. So we will see the echo now with Mohammed. Mohammed, you can continue now.
Okay, Dr. Karim. We can see the echo, as we just said, the left parasternal long axis view with the asymmetrical septal hypertrophy with the posteriorly directed mitral regurgitation and the aliasing here at the septo-mitral contact. Here we can appreciate the systolic anterior motion in this long axis view, apical long axis view. We can see the systolic anterior motion and the aliasing that is here in the LVOT. And again, in the four chamber view also, we can appreciate the systolic anterior motion. Here, the short axis view, we can appreciate the differential hypertrophy and the asymmetrical hypertrophy between the segments of the mid part of the ventricle. And here also we can appreciate the systolic anterior. So I'd like to ask you the first question in this session. What is, from your point of view, what is the pathophysiology of the mitral regurgitation in this case? First, systolic anterior motion, SAM. Second, presence of primary mitral valve abnormality. Third, both of them, 1 and 2. 4, none of the above.
So please respond through the chat and Facebook. Okay, Ahmed Saeed, do we have any insight from the Facebook?
Not yet. Mind you that there is a delay of nearly 15 seconds between Zoom and Facebook. So
Okay. So I think there is multiple answers that it would be the systolic anterior motion of the mitral valve. Yes, most of answer is denoting that the etiology is the systolic anterior motion of the mitral valve. Dr. Mohammed?
Okay, and this is the correct answer. That the pathophysiology here in this case is mostly due to the systolic anterior motion. And I'd like to comment in this point that the assessment of the mitral regurgitation in every HCM case is very, very important point, especially the direction of the mitral regurgitation, as there will be one of two options or one of two findings. It's either posterior directed, which is the most common, or anterior directed, which is less common. The posterior directed one is due to the systolic anterior motion, is due to the lack of coaptation between both mitral leaflets due to dragging effect of the LVOT obstruction on the anterior mitral leaflet. So the regurgitation will be in the opposite direction of the anterior mitral leaflet. On the other hand, the anteriorly directed mitral regurgitation usually is due to primary abnormality in the mitral valve, either abnormal papillary muscle insertion or any abnormality in the valve. And this is very, very important point before taking a decision in the septal reduction therapies later on. If we will do an intervention for this patient, this point is very important, as if it is posteriorly directed jet, only just correcting the LVOT gradient and obstruction will correct the mitral valve regurgitation without any intervention to the mitral valve. On the other hand, if it is anteriorly directed mitral regurg and the patient need an intervention for correction of the LVOT obstruction, usually the surgery is the best option for him, as the mitral valve abnormality must be corrected inside the operation. So in conclusion, if we found anteriorly directed mitral regurgitation jet, we should search for a cause in the mitral valve. This is the message that I want to say from this slide. And this is not our case that I'm just showing you. This is to see to show you that there is a hypertrophic cardiomyopathy with systolic anterior motion with anterior directed mitral jet. So in this case, we should search for the cause of the mitral regurgitation. This is not our case. This is another case to see you that there is anterior directed jet in the HCM, which denotes primary mitral valve abnormality. Also, I want to comment on the grading system of the SAM. The SAM has 4 grades, and the first grade, it is when there is no mitral leaflet septal contact, and the distance between the mitral valve and the septum is more than 1 centimeter. The second grade of the SAM, when there is also no mitral leaflet septal contact with minimum distance less than 10 centimeters, less than 10 millimeters or 1 centimeter. Grade 3 and 4, there is mitral septal contact, but the difference between them is the duration of the contact between the mitral leaflet and the septum. If it is less than 30% of the systole time, so it is grade 3. If it is more than 30% of the systole time, it's a grade 4. And from this grading of the same, we can suggest or we can predict the LVOT obstruction. Usually when there is a grade 4 SAM, usually there will be marked LVOT obstruction. When there is grade 1 SAM, usually there will not be marked obstruction. So in our case, there is no mitral septal leaflet contact, and the distance is less than 1 centimeter, so it is SAM grade 2. Another question. All these echo parameters, the following echo parameters are important in the sudden cardiac death risk calculation of the HCM cases, except maximum LV wall thickness, left atrial diameter, systolic anterior motion of the mitral leaflet, and the LVOT gradient.
So another question to be answered. So please respond in the chat box. So, Dr. Mohammed, some answer for Sam and some answers for the left atrial diameter.
Okay, Dr. Karim, the
answer for the left atrial diameter actually. What do you think, Dr. Mohammed?
The correct answer here is the SAM. The SAM is not an important parameter for the sudden cardiac death risk calculation, while the left atrial diameter is very important, as we will see later on.
However, it's important for LVOT obstruction.
Okay. What is the clinical significance of measuring the left atrial diameter during the echo evaluation? It has two important points, that the more the left atrial diameter and the more the left atrial volume and the more the left atrial area, the more risk of sudden cardiac death risk, and the more risk of developing atrial fibrillation. That's why the guidelines recommends that any patient with HCM in sinus rhythm with left atrial diameter more than 45 millimeter, he should undergo routinely every 6 to 12 months 48-hour ambulatory ECG monitoring to detect atrial fibrillation. So measuring the left atrial diameter during the evaluation of the HCM case and in the follow-up is very, very important. Here, our patient have left atrial diameter of 4.3. And here we measured the septal thickness. It was 3.1 centimeters, and the posterior wall is 1 centimeter. I'd like to comment on the mid-ventricular part. We should, in every patient with HCM, we should search for the mid-ventricular obstruction by putting our pulsed wave Doppler inside the LV cavity where we found any aliasing. This is very important because this must be corrected inside the operation if the patient will go for an intervention and he will not be candidate for alcohol septal ablation. So we should search for mid-ventricular obstruction. And finally, we document the LVOT obstruction firstly by putting our pulsed wave Doppler at the point of the maximum aliasing and to get the maximum LVOT obstruction along the LVOT. Here in our patients, the LVOT gradient at rest was 45 millimeter mercury. So we asked the patient to do Valsalva. The gradient increased to 60 millimeter mercury, and asked the patient to do bed size exercise. And the LVOT gradient increased to 21 millimeter mercury. A small comment on the provocative methods for the LVOT gradient. The guidelines recommend that we should do provocative methods for the LVOT gradient if it is reported at rest below 50. If it is more 50, there is no need to do provocative method. If it is less 50 and the patient is symptomatic, we should go for one of these parameters or provocative methods, either exercise echo, either Valsalva, vasodilators, and we'll see the vitamin. What is the most physiological method of this provocative method is the exercise echo, which may not be present in most of our echo labs. So we can off-labelly replace it by air cycling. We can ask the patient while lying down in the echo lab to do air cycling as in this picture. And we report for 1 or 2 minutes as the patient can withstand, and then report the LVOT gradient again. The Valsalva recommended by the guidelines to be done in the sitting and semi-supine position and standing. And the vasodilator is the third step if the patient cannot be exercised. And the guidelines don't recommend to do dobutamine as a provocative method for provocation of the LVOT gradient.
So nice demonstration of the echo findings regarding the diagnosis and the prognostic factors of the echo data for both management later on with, as we will see, and the application of risk factor for sudden cardiac death. Now it's a time with comment with Dr. Karim Saeed on the echo data.
Thanks, Karim. As you can see, echocardiography has a very pivotal role in the diagnosis, in the risk stratification, and in the guidance for the management of HOCM patients. And Muhammad had shown several important diagnostic features for HOCM, and I would like to add some added points. The first is a threshold to which we diagnose abnormal septal thickness in adult. It is recommended that wall thickness more than 15 millimeter is a classic threshold to diagnose abnormal wall thickness and to diagnose hypertrophic cardiomyopathy, among other features, of course. However, when we have a relative for a patient with definitive HOCM, the threshold is not 15 millimeter, it is 13 millimeter. Of course, this is for adults, not for children. This is a point. A second point, actually it is a question. Should we use the left ventricular mass index to diagnose hypertrophy among patients with hypertrophic cardiomyopathy? And the answer is no. Despite it is hypertrophy, the majority of HOCM patients do have normal left ventricular mass index. And so diagnostic criteria depends upon the wall thickness in short axis in one or more segments using echo or MRI. A third point is related to the differentiation between aortic stenosis, the fixed valvular aortic stenosis, and subaortic dynamic obstruction, which is the hallmark of hypertrophic cardiomyopathy. We should analyze the Doppler very carefully. And as Muhammad had shown, if you can, Muhammad, can you go back to the Doppler of your patients?
Yes, sir.
Doppler of the LVOT. Yes, we can use this. At the left side of the image, this is the Doppler of the LVOT, and we can see what is called the dagger shape. This concavity to the left, which is characteristic for the dynamic obstruction because there is rapid acceleration at the mid to late systole, which is very peculiar to HOCM. While in patients with fixed aortic stenosis, we do not see this dagger shape. We will see a symmetrical Doppler envelope. This looks like a tongue. And sometimes we have a reverse dagger shape. This concavity is directed to the right side of the frame. Another caveat in echo is the right ventricle. We should analyze the right ventricle very carefully in good proportion of patients, we will find hypertrophy of the right ventricle. In another good proportion, we will find obstruction of the right ventricular outflow tract, and some need correction during surgery. Also, we should give very good attention to the pulmonary artery pressure. Some HOCM patients do have severe pulmonary hypertension, and this have an impact on the management and on the medical treatment. Use of calcium channel antagonist in those HOCM patients with severe pulmonary hypertension is contraindicated because it increases the risk of acute pulmonary edema. And the final message at echo was shown by Muhammad, which is the importance of diameter. It is not volume, it is diameter. It can predict the risk of sudden cardiac death. It can predict the risk of atrial fibrillation, and it can predict the risk of stroke among HOCM patients. So echo is the most important investigation and should be done very carefully and very comprehensively among HOCM patients.
Thank you, Dr. Karim, for these nice comments. I just have two more comments regarding the site of hypertrophy. It can be any site. The most usual site is the septum. However, it can relate it to the mid cavity or apical or even to the posterior wall. The second comment, in the cases of mitral incompetence, we should, when applying the continuous wave Doppler, we should avoid the contamination by the mitral regurgitation jet, as this can lead to the false increase in the false assessment of the gradient across the left ventricular outflow tract. So, Mohammed, can you tell us what is the next step after the echo?
After echo, I'll give a comment on a very important point in the clinical evaluation of the patient, that we should know that we have a different causes for HCM. 60% of the HCM patient have sarcomeric protein gene mutation, which is the prototype of the HCM. But we have to know that about 10% of the HCM cases may be due to infiltrative diseases, glycogen storage disease as Bohm and Danon, Anderson Fabry's disease, may be due to neuromuscular disease, Friedreich's ataxia, due to malformations in Noonan-Leopard syndrome, may be due to amyloidosis, it may be due to other drugs. And about 30% of the patient, we don't know the genetic base of the HCM. I'd like to comment also that the most important gene mutation, or the most prevalent gene mutations in the sarcomere protein gene mutation are the myosin heavy chain and myosin binding protein C. And during the clinical examination of the patient, we should give attention to other features, signs and symptoms that suggest a specific diagnosis, as we just said. For example, if we found the patient have a learning difficulties, this may suggest that the patient has a Danon disease or Costello syndrome. If we found the patient has corneal obesities, so it may be Anderson Fabry's. If we found the patient that has a carpal tunnel syndrome, it may be amyloidosis. So all these clinical features must be asked and searched for during the clinical examination in order to correctly diagnose the patient. Also in the echo, if we found the concentric LVH, most probably this is a glycogen storage disease. If we found extreme LVH, the wall thickness is more than 30 millimeter, this may suggest Danon or Bohm disease. And the amyloidosis with its characteristics that we all know from increased interatrial septal thickness, increased AV valve thickness, and the pericardial effusion, the ground glass appearance. So the presence of RVOT obstruction, which may be present in the Noonan syndrome. So all these features may suggest a specific genetic causes other than sarcomere protein gene mutation. In the lab, in addition to the routine labs that we usually withdraw for the patient, we may see that when there is elevation of the liver transaminases, it may suggest diseases Danon and mitochondrial diseases. Also, we suggest that the patient have from the examination and the echo and the history that he have amyloidosis, we will go for urine and the plasma electrophoresis. Other tests as the plasma galactosidase enzyme may be done if we suspected Anderson Fabry disease from the clinical features that we just said. So, in conclusion, if this algorithm conclude what we just said, we have the patient here in the first step in the clinical evaluation. Will we draw a pedigree for him, see signs and symptoms, ECG, cardiac imaging, and lab, and we search for a specific feature suggestive of a specific disease, as Anderson Fabry's, BOM, etc., etc. If we found these features, we should go for specialized tests for these diseases. If we don't find features that suggest a specific disease, we will go for genetic testing. In the genetic testing, either we will reach a definitive disease, sarcomere protein gene mutation, or it will be from the 30% with no known genetic cause. Doing a genetic test for the patient is very important in HCM, and as per guidelines, it's a class 1 indication in the index case. And here in the in this right side of the slide, when we do genetic testing for the patient, we will have one of three different findings. Either we will find a definitive mutation, or no mutation, or we will find a variant of uncertain significance. Yeah, what's meant by variant of uncertain significance? That we will find a genetic defect, but it's not reported worldwide that this genetic defect is causing HCM. And we will find in each line how can we go. If we found a definitive mutation, we should go for cascade genetic test for the family members. And the family member who will be mutation negative will be discharged from the follow-up in the clinic. While if we found mutation positive, this patient will be followed up. On the other hand, if we didn't found any mutation, we didn't found any genetic mutation that's related to this HCM, we will go for cascade clinical screening. We will do screening for the family members only clinical. We will not do genetic test for these family members. And from these patients from these family members who will be normal, will be followed up at longer intervals. Who will be an HCM as the index case will be followed on short-term intervals. If we found the third finding, if we found a variant of uncertain significance, we can do Sig Regression Analysis. What is meant by Sig Regression Analysis? That we can do genetic test for the whole family member. If we found that genetic abnormality that's not reported worldwide, that's causing this myopathy, is present in one or more of the family members, and it is related directly, if the family member has the genetic abnormality, has a phenotypic features, we can report it worldwide that we find a new genetic abnormality related to the HCM. I hope this is clear.
Let's simplify the genetic testing because it looks more or less complex. So okay. I will ask you some questions and let you answer by the guideline, by book. So genetic testing for all patients or for all index patient with HCM, yes or no?
Yes or no? Yes, yes.
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 Okay.
If it has no feature suggestive of a specific disease,
okay,
like Danon or Anderson Fabris or like that.
Great. So genetic testing for all HCM except for those with specific disease.
Yes.
So the next step, family screening for all relative of the HCM patient, yes or no?
No, for only patient who will we find a definitive mutation, a known mutation.
Okay, so if you found a definite mutation, yes or no, family screening?
Yes, yes, family screening.
Okay. If you don't found a definite mutation, so you wouldn't do the genetic screening.
Yes.
Okay.
We will do only clinical examination.
Okay. So I think it's clear right now, and
I hope so.
I want to know how you draw your pedigree for this case, and you can help us in that. I know.
Okay. In every patient with HCM, we should draw a family pedigree. Simple rules for the family pedigree: we should draw 3 generations. Our case here is called the proband or the index case, and it is marked as red. We draw the 3 generations. The males are represented by square, the females represented by circle. If the 2 persons, the married persons, are not consanguineous, we withdraw or connect them by single line. If they are consanguineous marriage, we connect them by double line, as you see. If the patient of one of the family members is dead, as in our case, he had paternal uncle died, we just draw a line like this. This means that this patient died. If the patient has brothers twins, we draw it like that. If another brother which is not a twins, we draw it like that. So this is very simple demonstration for the pedigree. What is the importance of the family pedigree? It helps us a lot to know the mode of inheritance of the diseases. If we found that all generations are affected by the gene mutation, and in every generation there is cases of HCM, so this suggests that this disease is dominant disease. If we found that only males are affected by the disease and the females are carriers only, so this is a 6-linked disease. If we found that there are carriers and disease patients, and the disease patient must have the 2 alleles diseased, and the disease is not present on all generations, so it is autosomal recessive disease. So the family pedigree help us to know the mode of inheritance. After doing the genetic test for the patient, it was found that she had mutation in the myosin heavy chain 7 gene abnormality, and accordingly we did it in the relatives, and we found that one of her family member in each generation has the genetic defect. And all the genetic tests that are done in HC was done with the American College of Medical Genetics and Genomics, and this is an example of how the genetic test report is reported. In the top of the screen, we will find the gene, and the abnormality is missense mutation, and the guanine is replaced by thymine purine, and this is the location of the abnormality in the chromosome number 14. And this table further emphasized that this mutation is a pathogenic mutation. It's not a benign one. We can see the lighted words here that suggest or further emphasize that this mutation is a pathogenic and not a benign one. This is a brief example of how the genetic test report is done.
Okay, Mohammed, let's stop for some time and get the insights from Dr. Karim.
Thank you, Mohammed. You discussed a very complex issue, which is the use of genetic among HOCM patients, and you discussed the cascade screening and the questions given by Dr. Karim Mahmoud was clinically relevant for such a discussion. And I want to ask other two questions related to genetic testing apart from their use for screening of the family. The first, can you use genetic testing for risk stratifications of HOCM patients in terms of sudden cardiac risk, death? And the answer is no. Prior guidelines, the American guidelines, suggested the use of genetic testing as a risk enhancer for sudden cardiac death. If we found some mutations or multiple mutations in a HOCM patients, this may be used as a marker for increased risk of sudden cardiac death. Now, this direction is not adopted by the American or the European guidelines. The second question, can the genetic testing help us to establish the diagnosis of hypertrophic cardiomyopathy in some patients with hypertrophy who do not satisfy the whole criteria of HOCM, such as patients, hypertensive individuals with borderline hypertrophy, or athletes who have some hypertrophy related to their exercise? And this is also a very difficult question. If the mutation of HOCM, known mutations of HOCM, prove to be positive in those individuals, yes, we can use this genetic testing to establish the diagnosis. However, the problem is that we cannot rule out HOCM if we do not find a positive genetic testing, because, as you said, 30% of genetics related to the HOCM were not yet well characterized. So in some individuals, athletes or hypertensives with some left ventricular hypertrophy that do not satisfy the whole criteria of HOCM, we can use the genetics, which is off-label use or not recommended by all authorities, to support the diagnosis of HOCM if it is positive. However, if it is negative, we cannot rule out the diagnosis of HOCM.
Very valuable comments, Dr. Karim. Thank you so much. So back to Mohammed. And we have now a case of that has a different diagnosis with echo and a positive genetic screening. So what's your next step?
My next step, Dr. Karim, will be doing Holter monitoring, ECG monitoring 48 hours. And in our patient, it revealed infrequent attacks of non-sustained VT as we see in this ECG. Cardiac MRI, as per guidelines, it's a class 1 indication to perform cardiac MRI in any patient with HCM if it is available in your healthcare facility. And this is the cardiac MRI of our patient today. We can see the asymmetrical septal hypertrophy here with the left atrial dilatation, this is an 4-chamber view. This is an apical 2-chamber view. This is the anterior wall. This is the inferior wall, and we can see also the hypertrophy. And this is the 3-chamber view. We can see the anterior septal motion, anterior septal, the SAM with the aliasing here. And as you know, this is a long axis view of the LV. This is the late gadolinium enhancement view. We can see here the whitish area that is present in the septum, and here whitish area is present in the septum. This denotes the late gadolinium enhancement, which denotes the fibrosis that is present in the LV. This is a short axis view. This is the LV wall, and this is the RV wall. Okay, this is the points of insertion of the RV into the LV, and we can see the characteristic fibrosis of that is present in the LV at the point of insertion of the RV into the LV wall. This is whitish area. Okay, Dr. Ahmed Asfour.
So Ahmed, Dr. Ahmed Asfour, our MRI expert, are you with us? Okay, Mohammed.
Continue, and
we will continue, and Ahmed will discuss the CMR features at the end.
Okay. As Dr. Karim just said, this is a dilemma of diagnosing HCM in athlete patients or athlete persons, if we can say. As it will affect this athlete markedly, it will get him off from his sports and make him to make a shift in his career, and it may change his lifestyle dramatically. So the diagnosis of HCM in this category of subset of patients is very, very, very important, and it must be based on the majority of the clinical features that will we say in this table. From the demographic views, from the demographic points that we just said, we can apply this criteria on our patient. Our patient have family history of hypertrophic cardiomyopathy in the first degree relative. Yes, as we just said, by the family pedigree. She's a female gender. She has a family history of sudden cardiac death in her relative, which is was 39 years old. She has cardiovascular symptoms. She has abnormal Q wave in lead 3 and EVF. And she has complex ventricular arrhythmia in the 24-hour Holter monitoring non-sustained VT. All these features suggest that this athlete is hypertrophic cardiomyopathy rather than the normal left ventricular hypertrophy related to the training and exercise. And also the asymmetrical interventricular septal hypertrophy, the complete SAM, the left ventricular end diastolic diameter, when it is less than 45 millimeter, it denotes that the LV is very thick and the LV cavity is too small. The presence of late gadolinium enhancement is in favor of being HCM rather than athlete. No response to detraining after 3 months. We will say in space that for 3 months we did another echo for her. The same picture was present. So this hypertrophy that she had is not due to exercise, it's due to a disease. And finally, from the genetics, we emphasized that the patient have myosin heavy chain disease, and we found the mutation. So these features suggest that our patient is HCM, and the hypertrophy is not due to exercise or so from your point of view, what is the next step in the management of this patient? She is 19 years old, symptomatic, heart rate is 80, blood pressure 110/70. She's symptomatic. What is the next step? It is surgical or dual chamber pacemaker, or to limit her activities and have a good medical treatment in the form of beta blockers or calcium channel blockers.
So please respond, chat and Facebook. Here we have this patient with a significant left ventricular outflow tract obstruction, and she is symptomatic, and it's proven to be a hypertrophic obstructive cardiomyopathy by echo and the CMR. So we have the answer for one. While waiting the answer, Mohammed,
Yes,
can you tell us in summary what are the criteria for the athlete heart? You mentioned elegantly the criteria of hypertrophic cardiomyopathy, but what about the criteria? How you what are the echocardiographic and the clinical criteria of athlete heart?
Usually, but in the same, during the echo examination, the athlete heart mostly it will be a concentric hypertrophy, not an eccentric one. From the general look, firstly, mostly there will not be a SAM. The left atrium will not be markedly dilated. There will not be diastolic dysfunction. Also, mostly there will not be an LVT obstruction like the HCM cases. So from these features, we can also the LV diameter. The LV end diastolic diameter is usually more than 45 millimeter. So it has a big cavity rather than the HCM one. So from all these features, we can suggest that this is an echo of an athlete, not an HCM. And as we just said, we should take the majority of the findings and not depend on one clinical or one imaging modality to take a decision for any person.
So we have a multiple answer for one, surgical myectomy. What do you think?
I think the correct answer is not one. It's very important to know that the first step in any patient with HCM who is coming complaining that to first to limit his activity if he's doing competitive sports and to start medical treatment. Many of the patients, when you start medical treatment, get less symptomatic or even improved markedly on just decreasing the heart rate by beta blockers or calcium channel. So the best answer here, from my point of view, is, and from the guidelines, is good medical treatment and limitation of the training activities. We started bisoprolol 5 milligram, and we followed here.
Let's continue, Mohammed.
Before Professor Karim Saeed starts his discussion about this point, we'll be back to it again because Ahmed is here now. Ahmed Asfour, can you start sharing your slides, please, about the cardiac MRI features?
Yes, not now, Mohammed. Mohammed, it's
Okay.
not now. We're showing the CMR slides after the end of Mohammed.
After the end of the whole session?
Okay. After the end of Mohammed's session, presentation.
Okay. Okay, sir.
So continue, Mohammed, please. Why would you choose the medical treatment and the limitation of the physical activity for this patient before going to Dr. Karim?
We chose, as per guidelines, the first line of management of any HCM patient is to control him on medical treatment and to get his heart rate to around 60 before reporting that this patient is resistant to medical treatment and go for further interventions. Because as you know, any intervention has a lot of drawbacks. So first line of management of any patient with HCM is control him on medical treatment. There are also, in addition to the medical treatment, a lot of general lifestyle consideration we must inform our patient with, and we can choose from them what is reasonable for our patient. For example, in our patient, we should tell her to avoid competitive sports and to stop tennis playing furthermore, and to maintain healthy body mass index, to have less large meals or have no large meals, avoid dehydration and excess alcohol. And if we prescribe here verapamil, we should remember that verapamil is causing constipation. Constipation in a patient with LVOT gradient obstruction will make her to do valsalva during defecation, and this may make her to get syncope during this action. So we should take care of the medication. Also, if our patient is a male, he should avoid use of phosphodiesterase 5 inhibitors if he has sexual dysfunction, because this will increase the LVT gradient and increase his symptoms. The medication avoid the vasodilator in general. Driving, if the patient has syncope, he must avoid driving. His occupation is very important. If he's a pilot or any that is responsible for other lives, he should avoid to do that. If he has severe symptoms, and our patient's section will be next slide. On her regular follow-up after subtitration of bisoprolol to 10 milligram, reaching a baseline heart rate of 55 per minute. Her echo was repeated and showed the same picture without any hypertrophy.
Mohammed,
and further
Mohammed, before going to the next step,
what is the next?
I'd like to hear the comment, and I'd like to add a comment from Dr. Ahmed Shahata that in a young patient with a gradient more than 75 millimeter mercury, and as in this case with low surgical risk, you can consider septal reduction even without symptoms. So what do you think, Dr. Karim?
Okay, I will give a comment, then I will try to answer Dr. Ahmed Shahata's question. The management given by Dr. Mohammed Hosni is a standard and recommended by the American and the European guideline. We start with medical therapy for symptomatic patients who have obstructive cardiomyopathy, and surgery is indicated only for those patients who remained symptomatic, having a significant gradient despite optimum medical therapy. And the question here, what to give the patient? We have beta blocker and we have calcium channel antagonist. Which of which? Dr. Mohammed Hosni started with beta blocker, and this is a standard to give beta blocker for patients with obstructive cardiomyopathy, non-vasodilator beta blocker. The standard is the propranolol because it was reported in many studies. However, bisoprolol is a good option as well. And in this particular case, we should not use calcium channel antagonist. We should not use isopten. Why? Because in patients with severe LVOT, the use of calcium channel antagonist may be associated with increased risk of hypotension and sudden cardiac death. Why? Because calcium channel antagonist will induce vasodilation and reduction of afterload and increase in the LVOT gradient that may be precipitate worse cardiac event. On the other hand, beta blocker do not decrease the systemic vascular resistance. Actually, they may increase the systemic vascular resistance. So the hazard of CCB in those patients with severe LVOT should be taken seriously in those patients. Regarding the question given by Dr. Ahmed Shahata, beta blocker in many studies proved to decrease the LVOT gradient, actually to abolish the LVOT gradient during rest and during exercise. And so if we use a medical therapy, we can avoid the risk of surgery. And you not have data that surgery in those patients is beneficial. This is a point. The second point is that the prognosis of HOCM patients does not depend significantly on the magnitude of the left ventricular outflow tract obstruction. Actually, LVOT is not a major risk factor for sudden cardiac death. LVOT obstruction is not a major factor for the symptomatology or the prognosis. Of course, we have some studies that showed some association between LVOT obstruction gradient and the outcome. However, this is not the consensus. So we do not target the gradient. We are targeting the symptoms, the functional capacity, the risk of atrial fibrillation, and the risk of sudden cardiac death. So beta blocker can achieve all of these targets, apart of the risk of sudden cardiac death, avoiding the risk of surgery.
Thank you, Dr. Karim. So back to Mohammed. As guidelines stated, as Dr. Karim mentioned, the first line therapy is the medical treatment. And your patient, Mohammed, didn't respond to the medical treatment. So what is the next step?
So this is a question for the audience. And I'll answer this question before going deep into the interventions and the options. I'd like to make your attention to very important points that we should, in the clinical evaluation, search for other additional explanation for the symptoms of the patient. The symptoms of the patient may be due to respiratory disease, maybe due to anemia, maybe due to thyroid disease, maybe due to obesity. And also to illustrate the mechanism of obstruction, because the mechanism of obstruction will affect the decision whether to go for either or that solution. It is SAM related, it is mid-cavitary, it is related to anomalous papillary muscle. And finally, we should assess the mitral valve anatomy properly, and we should have at least 1.7 centimeter septal thickness to do our interventions. As per guidelines, the algorithm is clear. We assess our patient by 2D and Doppler echo. If the maximum LVOT gradient is more than 50 and the patient is symptomatic, we'll go for medical treatment. Then if it is persistent symptoms, we'll go for septal reduction therapies. If it is less than 50 and the patient is asymptomatic, leave him in peace. If he is a maximum LVOT gradient is less than 50 and the patient is symptomatic, we should go for provocation. If provocative method produce gradient more than 50, we shift to this line. If it is less than 50, we keep the patient on medical treatment only. And it's a +1 indication, as we just said, to go for intervention in patient with gradient more than 50 despite optimal medical treatment, and the patient have persistent symptoms, NIHA at least 3 to 4. So this is the dilemma of whether to go for surgical myectomy or alcohol septal ablation. And it's very important, the discussion, point of discussion. And before going deep into this discussion, I'd like to emphasize that till now, there are no head-to-head comparisons, trials of surgery, I mean myectomy versus alcohol septal ablation. So all the data present in the literature are derived from observational data and registries. There is no randomized controlled trials till now. There are certain logistic issues that affect the technique or the availability of the technique in each country. Some countries have the alcohol septal ablation option, some does not have. So this will affect our decision. the suitability of the anatomy to one of each technique. As we just said in the mitral regurgitation, if it is anterior directed, so there is no option for alcohol septal ablation if there is severe mitral regurgitation or at least moderate, and we have abnormality of the mitral valve, primary abnormality of the mitral valve. The risk of each procedure for the patient comorbidities. If the patient is high risk for surgery, so there is no option of surgery. Experience of the operators is very important point, and the patient preferences. And here on the right side, we can illustrate the pros and cons of each intervention. The surgical myectomy has a high clinical efficacy, high success rate more than 90%, low operative risk. But on the other hand, have a high surgery mortality up to 30% at inexperienced centers. On the other hand, the alcohol septal ablation is more widely available, it's less invasive, short hospital stay, successful in 80% of cases, so 20% of cases need re-intervention, and less favorable long-term survival in comparison to surgical myectomy. While the cons, that there is a risk of 10% that need pacemaker dependency after the intervention, and the presence of the potential scar in a vulnerable myocardium that may induce ventricular tachycardia or VF, and the high rate of residual or recurrent symptoms after the operations that may need re-intervention. And this is another algorithm that helps us to take a decision to whether to go for myectomy or alcohol septal ablation. We started here, adult patient with medical therapy resistant obstructive HCM. We will ask ourselves these questions. Is the patient have mitral valve pathology? If there is 3 vessel disease, if there is mid-cavitary obstruction, if the patient have one of these and he's fit for surgery, so we'll go for surgery. If the patient does not have any of these, we will ask about the presence of suitable septal perforator for alcohol septal ablation. If it is not present, so there is no option for alcohol septal ablation. We will go for surgery if the patient prefers surgery. If it is not present, we will see. Things is bromyectomy, that the patient, if he has pre-existing left bundle branch block, so it is more suitable to do myectomy, because all patients with HCM that undergo myectomy usually come with left bundle branch block after surgery. So if it is present pre-operative or pre-intervention, so the myectomy is the suitable option. On the other hand, if the patient has pre-existing right bundle branch block, so if he underwent a myectomy, he will have left bundle also. So 100% he developed complete heart block. So when the patient have a pre-existing right bundle branch block, it is more suitable for him to do alcohol septal ablation. And at the end of the day, it is a matter of discussion between the cardiac surgeon and the cardiac interventional consultant. Dr. Karim.
Thank you, Muhammad. You make it as if it is a controversial to do alcohol septal ablation or to do myectomy. And I want to give this rule: myectomy should be the standard and the classic and the fair choice and the preferred and the recommended method for septal reduction for several reasons. Now we have evidence, not now, it is more than decades ago, we have evidence that myectomy, successful myectomy, normalizes survival among patients with hypertrophic obstructive cardiomyopathy. They have a survival similar to the normal population. This data was not reproduced by any alcohol septal ablation register. Actually, we have some data showing increased risk of sudden cardiac death among patients having alcohol septal ablation. This may be related to the induction of infarction done by alcohol ablation. And most authorities in the field of HOCM do recommend myectomy when the surgical risk is not high and to be done in a good hand. And a point here, those surgeons who have adequate experience in myectomy are not prevalent. So we should refer our patients to a well-reputed center. And here in Egypt, in Aswan Heart Center, we have a very good success rate, and this should be the referral center for HOCM patients to have myectomy. One exception for this rule is in elderly patients. In elderly patients, we may offer alcohol septal ablation because their longevity is not going to increase by myectomy, and the risk of surgery is not low. Children and adolescents typically and classically should have myectomy, not alcohol septal ablation, because we do not have adequate long-term data for these patients. The risk of AV block, the risk of residual pressure gradient is higher in alcohol septal ablation cohort when compared to surgery. So the bottom line, we should refer our patients, young patients, HOCM patients, to myectomy as long as we have a good surgeon.
It's a very good message, Dr. Karim. In Egypt, we have the myectomy as a gold standard therapy, a gold standard septal reduction therapy, and the alcohol septal ablation should be reserved for the cases that won't be fit for surgery. So, Mohammed, what about the surgery?
She underwent surgical myectomy, Dr. Karim, and her follow-up echo revealed that the LVT gradient markedly decreased, her symptoms markedly improved, and this is her echo. We can appreciate the absence of the LVT aliasing that was present before, and also here in the apical long axis view, and also the decrease in the severity of mitral regurg without touching the mitral valve in the surgery. Here also we can appreciate the less SAM and the less LVT gradient. And the LVT gradient at rest was 13 millimeter mercury. She asked, back to our patient, she asked her consultant medical advice about marriage and conception, and she is worried about the possibility of getting a baby with a similar condition of her. So what will be your advice for her? And it is a question for you, my colleagues. The options: not to marry at all, or to marry but with contraception. The third option, to marry with genetic counseling if she wants to be pregnant. Or the fourth option, to marry and if she becomes pregnant, to do genetic test from the amniotic fluid to abort the baby if genopositive. What will be your answer?
So this is a very, very, very important aspect in managing the female with hypertrophic cardiomyopathy, the issue of pregnancy and marrying and pregnancy. So we have some answers for C, to marry with genetic counseling if she wants to be pregnant.
Okay, and this is the correct answer. What is the rationale behind this answer? First of all, when the patient come for us in the clinic and ask us this question, if she is sarcomeric protein gene mutation, these words can be applied on her. We can say for her that the risk of genetic transmission to her baby is 50%, so she may have all her babies free of the disease. All her babies may be from the 50% that will not have the genetic transmission. Secondly, even if the genetic transmission happened, the penetrance is not 100%. And even if the gene started to present its phenotypic features, the expressivity is variable. What is meant by expressivity? That the full picture of the HCM of the hypertrophy is not present, mild hypertrophy or something like that. And even if the phenotype is full picture and it is obstructive for say, the HCM is a medically manageable disease and the patient is usually have a normal lifespan. And it was stated clearly in the guidelines that the mutation carriers usually have a benign course, and most of the people with HCM are asymptomatic and have a normal lifespan. This further emphasizes that we should do pre-pregnancy risk assessment and counseling in all women with HCM, and the prenatal genetic diagnosis, which means to take a genetic test from the amniotic fluid, is not appropriate at all, and it may be prohibited in some countries. And the use of fetal echo to detect early disease is not recommended since the probability of cardiac expression in the fetus is extremely low, except in some syndromatic metabolic disorders.
So we have this female that she wants to get pregnant, and we are dealing with genetic disease that is autosomal dominant. So what's your advice for her, Dr. Karim?
Okay. This lady is very anxious about the future of her son or daughter, because she got the message she had a genetic disorder that may be fatal. And here I want to give two important pieces of data. The first data is that hypertrophic cardiomyopathy is a very common disease. In all textbooks, it is stated that the prevalence is 1 to every 500 individual among the population. This is an old figure. Now, after having the genetic study and the advanced imaging modalities, the prevalence is 1 to every 150 or less individual. The prevalence is 0.6%. So it is a very common disorder. The second piece of data, the prognosis of those 0.6% of population is very good. All in all, they have normal lifespan compared to the population. So how come that the HOCM had gained this bad reputation? Because the most HOCM literature was derived from a tertiary referral center. And the mortality rates were driven from very high risk individuals. They are very minority among HOCM patients. The risk of sudden cardiac death among the whole HOCM population is less than 1% per year. And this is normal. Only minorities, very minorities of those patients will have increased risk, and they can be detected by clinical or imaging data. So the message here to this lady is that she should not be anxious, and she can go for the marriage, and she can get her baby, and the whole concern will be related to the delivery circumstances and the period after delivery. And when her baby grown up and in the adolescence, we can screen him or her for the cardiomyopathy, HOCM, by the ECG, by the echo, and by testing him or her for the gene she has. This is the message. The majority, near all patients of HOCM do have very good prognosis.
So Mohammed, please continue.
Okay, she become married and now she's pregnant in her second trimester. What will be the frequency of follow-up in the clinic? It is a question and I will answer it. If it is it bi-monthly or every trimester or weekly or no need to follow up? The data are from the 2018 guidelines for the management of cardiovascular disease during pregnancy. And in this very nice table, we can demonstrate that our patient being hypertrophic cardiomyopathy without significant obstruction is modified WHO function class type 2 to 3. And the risk of cardiac events is 20%, 10 to 18%. And it should follow up in the clinic bi-monthly. However, we should emphasize on if the patient has HCM and has severe symptoms and have severe obstruction, LVT gradient more than 50, it is class 4 indication. It's class 4 to get pregnant. She has a clear contraindication for pregnancy, and she will be treated like severe symptomatic aortic stenosis. Also, if the patient developed systemic ventricular dysfunction and with ejection fraction less than 30% or NIHA function class 3 or 4, also it will be contraindication to be pregnant. Do you, sir, Dr. Karim, want to comment?
I think we can continue, Mohammed. Go on.
Okay. 2 years later, she developed the attack of rapid atrial fibrillation, after which she became markedly distressed. So, what is the appropriate management decision? It is rhythm control strategy or rate control strategy.
رزم طبعا.
Rhythm control. Do you hear me?
Yes.
Okay. The second question, her chat VASC now is 1, being female. Which of the following would you recommend? No antithrombotics at all, or aspirin is enough, or oral anticoagulation if she developed the cerebrovascular event? This is a question for you.
Okay, I think most of the answers go to number 3, oral anticoagulation.
Yes, I'd like to emphasize that in HCM patient, we should not use the chat VASC classification to predict the thromboembolism, and any patient, HCM patient with atrial fibrillation, should go for an oral anticoagulation directly, whatever the type of the clinical type of the AF, it's persistent, permanent, or paroxysmal AF. And the second thing I'd like to emphasize that restoration of sinus rhythm in this patient is very important, because they markedly depend on the atrial kick of the atrium. They have marked diastolic dysfunction, and when they get they have atrial fibrillation, they lost the atrial kick, and their symptoms markedly aggravated. So as much as you can, you should maintain sinus rhythm in these patients. Another question, and this is the last aspect, inshallah, in our lecture. From the previous information, what is the sudden cardiac death risk of this patient? How to calculate it, and is she indicated for ICD or not? And as stated by the European guidelines, we should we will give a comment on the risk factors for sudden cardiac death risk. First of all, the risk factors is the age, and I'd like to say that the age, as long as the patient is younger in age, the risk of sudden cardiac risk is more. The presence of non-sustained VT in the Holter monitoring per se, its presence, whatever the frequency or the duration. The frequency or the duration does not affect the risk, but only the presence of non-sustained VT is a risk factor for sudden cardiac death. The maximum LVT, left ventricular wall thickness, as the more LV wall thickness, the more risk of sudden death, and patient with maximum alveolar thickness more than 30 have the highest mortality rate or sudden cardiac death risk. Also, the family history of sudden cardiac death, which is very importantly to comment on. What is the definition of family history of sudden cardiac death in HCM? The definition: if the patient died before the age of 40, whatever he was diagnosed as HCM or not, or if he died at any age but with diagnosis of HCM, died at the age more than 40 but with diagnosis of HCM. If he died less than 40, even without diagnosis of HCM, we can consider this as a risk factor or a definition of sudden cardiac risk, sudden cardiac death in the HCM. The presence of unexplained syncope. Unexplained, it means it's not explained by the LVOT obstruction. The left atrial diameter, as we said before in the beginning of our session, and the left ventricular outflow tract obstruction. Also, the more LVOT obstruction, the more risk of sudden cardiac death. And finally, the exercise blood pressure response. And I'd like to say that failure to increase by at least 20 millimeter mercury from the rest to peak is considered a high risk feature for sudden cardiac risk. And decrease of the blood pressure from the baseline is a very poor sign for this patient. And as the guidelines released this HCM risk sudden cardiac death calculator, and we calculated the risk of in our patient. It is a weight-based calculator. Her age is 19 years, maximum alveolar thickness was 31, left atrial size 43, and the maximum LVOT gradient 121. She has a family history of sudden cardiac risk. His paternal uncle died at the age of 39, and non-sustained VT and the Holter monitoring. She has no unexplained syncope. So the risk of mortality at 5 years is 19%. So the guidelines, it is recommended, and this algorithm further illustrates the risk score that this patient is high risk, and the 5-year risk is if than 6%. So the ICD should be considered. But on the other hand, I'd like to remind you, and it is stated in the guidelines, that we cannot use this risk calculator if the patient is less than 16 years of age, or if it's not validated before and after MACT or alcohol septal ablation. So in real life, in HC, we don't do primary prevention for these patients because most of our patients did myectomy, and there is no data or validation of this sudden cardiac risk calculator after myectomy. And this is a very important area of research, and there is no evidence till now around this area, whether to use this risk calculator after myectomy or not. Dr. Karim?
Okay, Mohammed, before reaching your final conclusion, you showed that ICD is very useful in the patient for secondary prevention of sudden cardiac death. However, we have some debates regarding the primary prevention of sudden cardiac death. We'd like to hear from Dr. Karim about that.
Again, this is very controversial issue. For the estimation of risk of sudden cardiac death, we have two schema. The classic one is that reported by the American Heart, and the new one that is adopted by the European Society of Cardiology, which uses the risk calculator. The risk calculator was introduced in these 2014 guidelines, and at the time it was introduced, it was not validated. And after its introduction, the Americans, by Barry Maron is one of the fathers of HOCM, applied this risk calculator on the American database for HOCM, and it doesn't work. And accordingly, in the 2017 ACC/AHA guidelines for sudden cardiac death and ventricular tachycardia, this risk calculator was not used. And still, we use the classic schema in which we implant AICD for patients with family history, for patients with syncope, or patients with non-sustained VT or abnormal blood pressure response to exercise plus risk enhancer, such as lead gadolinium enhancement and others. And LVOT is not a major risk criteria, the pressure. So till now, we do not have the strong, accurate risk predictor, and all these criterion are not sensitive, and all this model is not accurate for the prediction of sudden cardiac death. I will give you an example. Syncope. It is known from the studies that syncope carries risk if it occurs in young patients and only during the first 6 months after syncope. Afterward, syncope do not predict sudden cardiac death. This was not taken in the risk calculator. This was not taken in the schema. In this European calculator, for example, wall thickness more than 35 was associated with decreased risk of sudden cardiac death, some statistical issue. So we should use our common sense and other features such as the very malignant history profile in the family of these patients. But there is a consensus that after myectomy, all these schema are not applied. And as I mentioned before, myectomy normalizes the lifespan. And as Muhammad said, in Aswan Heart Center, after myectomy, AICD is not inserted, and follow-up showed very good prognosis for follow-up period more than 10 years. This to conclude about the risk calculator for sudden cardiac death in HOCM patients.
So do you agree, Dr. Karim, this is from individual aspect? In a country with a limited resources such as our country, is it reasonable to follow up the patient after myectomy, and if she has no symptoms and no malignant arrhythmia, we can postpone or we cannot implant the ICD for this patient?
All these patients, of course, are followed, and if they have evidence for increased risk of death, and here evidence such as serious ventricular dysrhythmias or syncope, we can think on such cases. But also I want to emphasize on a point. AICD implantation in a HOCM patient is not this benign procedure. Why? Those patients are young. AICD implantation is associated with 1, increased risk of inappropriate shock, 2, increased risk of endocarditis, 3, increased risk of implantation of the battery and of the lead, 4, psychological burden. It is not this easy task. The first appropriate shock after implantation of AICD for primary prevention occur in the average after 5 to 10 years. And by experience, after myectomy, those young patients do have a very good follow-up.
Thank you, Dr. Karim. Dr. Haytham, are you with us?
Yeah. Yes, Karim, I am with you.
If you want to put some question from the Facebook and chat to Dr. Karim Said and Muhammad Hosni, please ask.
Yeah, we have some questions from the Facebook. The first one is about the grading of LVOT obstruction. Can we summarize the grading of LVOT obstruction in 2 or 3 words?
Yes, I can summarize it. It's simply if it is less than if it is more than 50 millimeter mercury, so this patient will go for medical treatment. If it is resistant to medical treatment and still more than 50, so he will go for intervention. If it is less than 50 and the patient is asymptomatic, leave him in peace. Less than 50 and is symptomatic, we should do provocative method to see. If it is more than 50, we'll go for the interventions, يعني septal reduction therapies. If it is less than 50, just will keep him on medical treatment.
Okay.
Sorry, it's more than
okay. So the other question is about this case, this particular case you showed Muhammad elegantly. Why to do an exercise test when the Valsalva gradient is 60 millimeter mercury? So what was the purpose of doing another exercise test when the Valsalva showed an increased gradient of 60 millimeter mercury?
Oh, there is no added benefit at all, but just to illustrate what is the different methods of doing the provocative method. But the one who asked the question is true. It was no added benefit to see that the LVOT gradient is increased above, it reached 60 and more than 50, so there is no added benefit. It is just to discuss the different options of provocative method.
Okay, great. Another question is if there is any genetic test available in Egypt and where?
It is available in Aswan Heart Center, but for HCM patients only and their families if they are followed in our clinic. I don't know other areas that have genetic tests.
I think المركز القومي للبحوث has the genetic testing.
Okay.
There is a question that Dr. Karim Saeed elegantly answered during the discussion. Is for patients with ICD by guidelines, indicated for AICD by guidelines. If she did myectomy, do we still need to implant an ICD or not? And Dr. Karim said elegantly that during the follow-up of the Aswan Heart Center series, these patients did not need any ICD with the extended follow-up. Is that correct?
Yes.
Yes.
Okay. The last question is, do we have to implant an ICD for a 50-year-old patient with only a non-sustained VT?
50 with non-sustained VT only?
Yes. Yes.
What about the other parameters for the risk calculator?
This is the only available data.
Yeah. I can answer generally, as we just said, as the more age of the patient, the less risk of sudden cardiac death. So if the patient is okay and have only non-sustained VT in his echo and his symptoms is okay, LVOT gradient is not so much high, less than 50 to be specific, has no other high risk features of sudden cardiac death in his family or unexplained syncope, I think he can go for medical treatment only and he not need to insert an ICD.
Okay.
And the same by the American.
I think Dr. Karim Saeed.
By the American guidelines, non-sustained VT is not a major risk factor, such as family history or syncope within 6 months or wall thickness. It should be combined with other high-risk features, such as aneurysm or ejection fraction less than 50, or risk enhancer, such as age less than 30 years, or high LVOT gradients, or late gadolinium enhancement. So non-sustained VT per se should not be an indication for AICD.
Okay.
Especially
the last question.
In all patients.
Okay. The last question is, what's the physical activity allowed for patients after doing myectomy?
This is very, very important and elegant question. And usually our patient asked us this question. We can say simply for them that he can do light sports, light to moderate sports with no ما يكونش فيها تنافسية with
non-competitive
non-competitive
sports.
non-competitive nature. He can do any light to moderate sports without any non-competitive feature. He can walk, he can jog, he can but with no competition with others.
And for these particular patients, with tennis, she will not be allowed to play single tennis as a single player, because it is graded as I think between 0 to 1 on the risk of sporting. It should not be allowed. However, she can do dual tennis with others. This is graded as 4 or 5. She can play dual tennis.
Okay. So I think these are all the questions on Facebook, and thank you very much.
Thank you, Haitham. And reaching for your final comments, Dr. Mohammed Hosni.
My final comments that the management of HCM cases need a multidisciplinary team, including cardiologists and cardiac imaging colleagues and cardiac surgeons, and long-term follow-up to detect complications as we just see in this patient and probably managing it. And we emphasized in our session about the general lifestyle recommendation for the patients and genetic counseling before conception, restoration of sinus rhythm in AF patients, sudden cardiac death risk prediction and the dilemma and controversy, and how to deal with it. Thank you very much.
Thank you, Dr. Mohammed, for this elegant presentation and the nice demonstration of the case. Can you please stop sharing your screen?
Okay, sir.
And I have the honor to introduce my dear friend, Dr. Ahmed Asfour. Please, Ahmed, share your screen. Ahmed is an expert in the MRI, and the MRI is a cornerstone in the diagnosing the hypertrophic cardiomyopathy. Ahmed will present a very good imaging regarding the hypertrophic cardiomyopathy and the value of the hypertrophic MRI in the hypertrophic cardiomyopathy.
Good night. Sorry for keeping you awake for all of this time. I will be concise as much as I can. I will go directly to my presentation, skipping the definition, just taking the most important part of it, that any LV increasing wall thickness more than 15 millimeter is considered hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy has different genotypes and phenotypes. We will try by cardiac MRI to differentiate between them as much as we can. There are a lot of, let me remove this. Okay. There are different causes of hypertrophic cardiomyopathy. Dr. Hosni mentioned them, so I will skip it. And going to the European recommendation for cardiac MRI in this disease. So we can see that cardiac MRI has recommendation class 1B. If you suspect that the patient has hypertrophic cardiomyopathy and your echocardiographic window is not adequate. And it is class 2A for any patient who is diagnosed by echo as hypertrophic cardiomyopathy to assess the cardiac anatomy, the function, and the extension of fibrosis. It's class 2A for any patient with suspected apical hypertrophy to diagnose whether there is an aneurysm, which carry high risk for sudden cardiac death. And it's class 2A also if we suspect cardiac amyloidosis, which present as a hypertrophic cardiomyopathy. And finally, in the intervention, in preparing for the intervention, whether it's myomectomy or septal ablation. So these guidelines summarize the role of cardiac MRI in this disease if there is inadequate images by echo, and to assess or give more data about the anatomy, the function, the fibrosis, and ruling other causes of hypertrophic cardiomyopathy, and for preparation of intervention in this disease. You mentioned the European scheme or algorithm for ICD, and it didn't mention the role of cardiac MRI in this algorithm. But the American one, they put the cardiac MRI as a rest modifier with the non-sustained VT regarding the amount of lead gradient enhancement. And there is a consensus about how much lead gradient enhancement is considered rest modifier, and it is roughly between 10 and 15%. And I will mention how to assess quantitatively the amount of lead gradient enhancement. Also, they mentioned that apical aneurysm as detected by cardiac MRI, which sometimes is confusing to be detected by echo. Apical aneurysm by itself is considered a rest modifier, and even without lead gradient enhancement. I will go through each one of the data that we can gain by cardiac MRI, starting by the morphology. So the cardiac MRI has much higher spatial and temporal resolution than the echo. It's a topographic imaging. We can take cuts in the heart at any topography. So in like this image, we can divide the short axis into unlimited amount of images so that you can very accurately define where is the hypertrophy exactly, whether it's basal anterior, whether it is apical lateral, whether it is circumferential, concentric, or whatever. It gives more data about the morphology of the mitral valve and the papillary muscle. And now we have data saying that the anterior mitral leaflet length by itself is considered a primary phenotypic expression of this heterogeneous disease. So it could be there independently of other variables, even without hypertrophy of the muscle. And the abnormal papillary muscle insertions also is considered now a primary phenotypic expression of this disease, whether it is like in this case inserted in the base or the mid of the anterior mitral leaflet. The anterior mitral leaflet tip is here. So all of this is the anterior mitral leaflet, and the papillary muscle inserted to the mid or the base of the anterior mitral leaflet, and this increase the risk for LV outflow obstruction even without significant LVH. Going through some cases quickly, this is a case of mid-cavitary obstruction that causes an apical aneurysm, and usually this aneurysm is fibrosed. Lead gradient enhancement almost transmural in this aneurysm, and this entity by itself carries high risk for sudden cardiac death due to high risk of arrhythmias. And by what we call phase contrast images, we can map the velocity of the flow across this mid cavity, and we can take a cross-section short axis image to see the flow and quantify it as forward and backward and peak velocity. Very similar to echo, but it usually underestimates a little bit the readings on the echo. So they are not in the guidelines, so you cannot take a decision whether this LV outflow tract obstruction is significant or not just by cardiac MRI, but it adds more data, and it makes you more sure about your echocardiographic data. Another case, this is a very simple case of hypertrophic cardiomyopathy with basal septal hypertrophy. But actually, when taking more detailed images, we can see that there is an abnormal signal intensity in the basal inferior intralateral wall, which actually by tissue characterization turned out to be a lipoma. So not all hypertrophic ventricles are hypertrophic cardiomyopathy, the genetic sarcomeral type of hypertrophic cardiomyopathy. It could be other causes like this patient who has just a lipoma, or sometimes a fibroma, or sometimes the lead gradient enhancement is taking a different position that is more towards the basal infralateral segments, which carry high risk, or not carry high risk, which suggests that he might have some other diseases that is phenotypically similar to hypertrophic cardiomyopathy, like Fabry's disease. This is another case of hypertrophic cardiomyopathy by echo and typical chest pain, and it turned out to have a normal epicardial coronaries. So what data can cardiac MRI add to us? When we did a wrist perfusion images, we can see areas of signal loss here and there and there. And this means that this patient has a microvascular disease. He has a problem at the level of the capillaries, not at the level of the epicardial coronaries. And that's very bad prognosis. And that's explain why the patient has typical chest pain with normal epicardial coronaries. And on lead gradient enhancement, we can see the typical lead gradient enhancement in the thickened areas. It's a patchy enhancement. But the lead gradient enhancement by itself can differentiate between whether this is just a hypertrophic, physiological hypertrophic heart, like a hypertensive heart, or pathological hypertrophic heart, like the genetic mutation, the inherited type, or it is just hypertrophy due to other cause like amyloidosis. When you see the circumferential enhancement, subepicardial enhancement, that speaks of amyloidosis. And we have other methods by cardiac MRI like T1 mappings and TI scout to diagnose amyloidosis and differentiate between the hypertrophic other types of hypertrophic cardiomyopathy. This is a different patient, 30 years old black woman coming with, again, typical hypertrophic asymmetrical hypertrophy in the basal anterior septum. But when we injected the lead gradient enhancement, we can see transmural jet-wide enhancement involving the whole septum and part from the anterior wall. This is not the typical image for hypertrophic cardiomyopathy, which shows a patchy enhancement in hypertrophic areas like this or like this. But when it's transmural enhancement, jet-wide enhancement, very high signal, this is not the typical for genetic type of hypertrophic cardiomyopathy, the inherited type of hypertrophic cardiomyopathy. This speaks more of sarcoidosis, and this patient actually had sarcoidosis, and she was put on beta blockers for years before this diagnosis. And when she presented with this cardiac MRI, she already starting to have a conduction problem, and eventually she ended up by putting a pacemaker. And again, you can see this jet-wide enhancement taking the whole anterior wall. That's a non-caseating granuloma, not a muscle disarray like the one we see in hypertrophic cardiomyopathy. Cardiac MRI, we add better spatial and temporal resolution to assess the SAM, and you can see it very obvious here how this anterior mitral leaflet is sucked into the LV outflow. And the cardiac MRI will add very accurate assessment of the thickness and the maximum part, the maximum thickened part of the septum, how far it is from the right coronary cusp, because that's important for the surgeon to know whether he's going to extend his resection deep. Because usually it's aorta, trans-aortic approach, so he will need to extend his incision deep if the thickness is more basal, more mid than basal, or if it's all basal, not mid. And sometimes you direct him to have an apical approach also, so that he can resect all the thickened muscle. That's again another image, and you can see here that this anterior mitral leaflet doesn't look of normal length. You can see this length is, by eyeballing, it's abnormally long. If we measured it here, it's almost 4 centimeters. Any anterior mitral leaflet more than 3.5 centimeters is considered an abnormally elongated anterior mitral leaflet. And as I mentioned in the beginning, this is one of the primary phenotypes, phenotypic expressions of this disease. Finally is intervention. Whether the cardiac MRI will help you in intervention, yes. It will the most important part is that it will very accurately give you the estimation of the true thickness of the muscle, excluding the septomarginal trabeculations, the cresta supraventricularis on the RV, and excluding the bias of taking your cut in the short axis in the echo oblique, not dead perpendicular. And it helps in the follow-up of these patients, and you can differentiate here between the images that revealed after myomectomy and those that are shown after ablation. You can see that ablation carries the risk of residual scarring in this shrinked septum, while post-myomectomy, the muscle is totally normal, and that explains the fear of Dr. Karim Saeed that post-ablation cases, they still carry risk for ventricular arrhythmias. On the other hand, the post-myomectomy patients, they get out of the operation with totally normal heart with no scars at all. So we ran through all the data that the cardiac MRI can give us in this disease, and my take-home message is simply CMR should be done in any patient with LVH. Thank you so much.
Thank you, Dr. Ahmed Asfour, for this concise, elegant presentation. I think we move a step forward with the cardiac MRI in the hypertrophic cardiomyopathy, regarding not only diagnosing the features of HCM such as SAM and thickness, but also diagnosing the etiology of the HCM, detecting some more features such as microvascular disease and the extent of fibrosis that can have a prognostic value. And as you said, also the follow-up of the patient after the intervention. So, Dr. Karim, would you comment?
One single comment for HOCM patients: one, multidisciplinary team; two, expert centers. Multidisciplinary team that include cardiologist, echocardiographer, CMR consultant, and for further management, pharmacist, good obstetricians, genetic expert, and this within the umbrella of center of excellence.
So we have a final question to you, Dr. Ahmed and Dr. Karim. Dr. Hatem Sukkari asked if cardiac MRI should be done for any patient with left ventricular hypertrophy.
Yeah, it is the answer.
Maybe unexplained left ventricular hypertrophy or disproportionate left ventricular hypertrophy.
Yes, I think so.
Yeah, it should be unexplained, if not explained, but hypertensive left ventricular
I would say
hypertrophy.
even if it's explained, like in some cases with aortic stenosis, finding lead gradient enhancement in these cases carries more risk for sudden cardiac death of these patients. So if maybe not for answering a clinical question, but for risk stratification, yes, even if you have a LVH due to aortic stenosis or hypertensive, severe hypertensive heart disease patient, yes, lead gradient enhancement carry more risk for these patients, so it could help in risk stratification.
So,
what's the criteria for that patient to do? I have a lot of patients with hypertension, left ventricular hypertrophy. Which patient I will choose to do CMR?
Guidelines is saying that suspected hypertrophic cardiomyopathy do cardiac MRI.
So it's unexplained left ventricular hypertrophy, especially in the young patient with absence of comorbidities such as hypertension, or if this patient have a marked left ventricular hypertrophy that is disproportionate to the degree of his blood pressure. I think this patient would benefit from cardiac MRI.
Yeah.
So thank you all for joining us today, and we reached to the wrap up, and I make some points regarding this very important topic. we talked today about the HCM, which is defined as a thickening of the one or more LV segment, usually above 15 millimeter. And it has different causes. These causes can be sarcomere mutation or glycogen storage, neuromuscular or mitochondrial disease, or amyloidosis. And we should differentiate between the HCM and athlete heart, especially in this young patient, young athlete patient. We have multiple modalities for diagnosing HCM, such as echocardiography and cardiac MRI. Genetic screening is important to diagnose the gene mutation in the proband and do family screening for this type of patient. And if we diagnose the patient with HCM, we should tell him some recommendation regarding a lifestyle modification, especially regarding the exercise and the pregnancy. Medical treatment is the first step, and if the patient remains symptomatic despite the medical treatment, so septal reduction therapy, preferably myectomy, is the gold standard therapy. And for the prevention of sudden cardiac death, ICD is class 1 for the patient with a secondary prevention of the sudden cardiac death, and the primary prevention is a debatable issue that should be individualized till now. And we should remember that atrial kick is very important in the patient with HCM, and the patient with atrial fibrillation should be restored to sinus rhythm and should have anticoagulation. Thank you so much. Thank you, Dr. Karim. Thank you, Mohammed Hosni. Thank you, Ahmed Asfour. Your presentation were elegant. And back to Dr. Mohammed Zahran to finalize this webinar.
Thanks a lot, everyone. It was a great session. Actually, lots of science was discussed here. What's the best about that is that the best experts in Egypt and probably in the region were collected, and I'm honored to have you all on board here. So thank you, every single person. Thanks to the CEC board as well. Next Saturday, we will have a very interesting webinar at 9 p.m. about atrial septal defects, congenital heart diseases. We have 8 interesting cases. So stay tuned. This is going to be a very interesting webinar, and hopefully it will catch your attention and admire as usual. Thank you so much, and see you Saturday. Bye-bye.